Hello everyone. I hope I am audible. My voice is clear. Okay. So today we'll start with intraoral examination. So okay. So we'll cover the soft tissue examination and hard tissue examination. Okay. In soft tissue examination, we'll cover lips, buccal mucosa, hard palate, soft palate, mucobuccal fold, oropharynx, tongue, floor of the mouth. And in hard tissue examination, we'll cover teeth. So first and foremost, you have to follow the journal guidelines. Like always, you should have a systemic approach to examine each and area. Okay, you should not miss so that to avoid any like if you just go abruptly to one or the other area, there is high chance that you might miss some important part. So better to follow one systemic approach. Okay, and you should have a complete visualization when you are examining any part of the oral cavity. You should have a good illumination. Okay, you should properly adjust your light so that you don't miss any important findings. And also, as we all know, there should be a good knowledge of normal anatomical structure if you want to differentiate it from the abnormality. So to know what is abnormal, first and foremost is you should know what are the normal structures. Okay, normal landmarks. So always when we are doing the examination, we do it in the four step. First is inspection, then palpation, percussion, and auscultation. Okay, percussion we usually do for the teeth. Okay, and auscultation for the TM joint. So first and foremost, lip. How do you examine lip? So we begin the examination by observing the lip. Okay, you can see with the help of pointer. Okay, see. First and foremost, you have to examine the lip in both the open position and the closed position. When you see the lip, you have the upper and the lower lip, and this is vermilion. Okay, this is the upper vermilion and lower vermilion. Okay, and this junction between the lip and the face or the skin is vermilion border. Okay, and these are the commissure areas, and this is your philtrum. Okay, these are the anatomic structures. Okay, so if you see any change in the color, texture, if you feel any growth is there, any ulcer, any pigmentation, you have to record it. Okay, and here look for the even coloring, and there should be a sharp demarcation between the vermilion and the face. Okay, and see here very sharp demarcation is there between these two. This is your philtrum, these are the commissure areas, and this is vermilion and this is a vermilion border. Okay, so you see here, if you feel any pigmentation, any white lesion, red lesion, or any ulcer, any growth in this area, you should record it. Okay. Next is, what are the pathological findings you usually see around the lip? So first is, if you see this picture, can you see here there are fissure at the corner of mouth? This is angular cheilitis. Okay, mostly angular cheilitis you see in patient who have reduction in the mouth opening. Okay, especially in the denture wearer whose vertical dimension is completely collapsed. Okay, or in patient who have severe anemia. This is commonly seen in those patients. So patient who have collapsed vertical bite, like especially the edentulous patient, or patient who have removed their molars, especially the 6 and 7 at a very early age, they have a collapsed bite. So the saliva will start accumulating at the corner of mouth, and which can lead to fissures and crackling. Okay, so this is angular cheilitis. There is another condition which is herpes labialis. Okay, if you see in herpes labialis, you will see the crustation. Okay, sometimes it appears similar to the angular cheilitis. But how do you differentiate herpes labialis from angular cheilitis? See, sometime, if they occur at the corner of mouth, herpes labialis, if it occur at the corner of mouth, it will appear same like angular cheilitis. So how you differentiate? See, herpes labialis is a viral infection, so it will have all the prodromal symptoms like fever, sore throat, lymphadenopathy, and then followed by that there will be formation of vesicles. Vesicles means blisters containing fluid. Okay, so that blisters will rupture and form ulcers, and which will lead to these crustacean. These are the, then they will heal after crustation. So sometime you will see these lesion at the corner of mouth. That time it is very difficult to differentiate it from angular cheilitis. So make sure you take a proper history of fever, sore throat, okay, and ask for the vesicle history or ulcer history so you can easily differentiate it. Also, this is a condition where, this mostly seen in people who are exposed to direct sun, like people who work come throughout the day in extreme conditions like sunny condition. Okay, you see here there is no demarcation between the lip vermilion border and the vermilion. Can you see this demarcation is not there? It is commonly seen in the actinic cheilitis, like people who are exposed to sun. Okay, next is examination of the labial mucosa. So how do you examine labial mucosa? You retract the lip completely with both your hands. Okay, uh, and then you examine the lower labial mucosa and the labial frenum. Same for the upper labial mucosa and the labial frenum, and check for any kind of color, texture, any swelling or any abnormalities like ulcer, red lesion, white lesion. You should check, and always do the bidigital palpation to look for any kind of lumps or swelling if it is there. Bidigital or bimanual bidigital palpation is that one hand of your finger is inside and the other hand is outside. This is bidigital palpation. Now these are the normal variation which we see in the labial mucosa, and they are also seen in the buccal mucosa. Okay, this is fordyce granule. These are yellowish pinpoint areas. These are nothing but the ectopic collection of the sebaceous gland. So it is a normal variation of the mucosa, and it is seen mostly in 80 to 90% of the population. Next is buccal mucosa. How do you check for buccal mucosa? You ask the patient to open the mouth and retract the cheek with the help of retractor or your mouth mirror. Okay, but make sure when you are examining it that this part will be covered with the retract. So make sure you move it up and down so you don't miss if there is any finding in this particular area. Okay, because this area is covered, so you move it up or down to make sure that you are not missing this particular area. And okay, and you have to examine from the commissure area, this is the commissure area, up to the retromolar area or the pharyngeal areas, and look for any kind of pigmentation. Okay, or if you see any ulcers, any red lesion, white lesion, anything you see, you have to record it. Okay, or any growth. Usually the mucosa is soft, the mucosa is smooth, moist and shiny because of the presence of salivation. Okay, and also you should do the palpation if you feel any kind of swelling is there, and same way you have to do bidigital palpation. One hand will be inside the buccal mucosa and other hand will be outside. Okay, and people who have xerostomia or reduced salivation, the mirror, this mirror is usually it doesn't stick to the mucosa. Okay, it is free flowing, but if patient who have reduced salivation, the mirror will stick to the mucosa. Also, when you are checking the buccal, examining the buccal mucosa, you have to also examine salivary glands. Okay, and there is the opening of salivary gland. uh, Sorry, my battery is down, so I'm just have to correct it. Okay, when you are check for the opening of Stensen's duct. Okay, so where they open opposite to the third molar, sorry, second molar area. Okay, 1 minute, guys. Okay, so sorry, my this thing was not working, charger, so I just reconnected. Okay, so your Stensen's duct open opposite to the second molar. You can see here this is a parotid papilla. So how do you examine it? First, you have to wipe this area, or you have to take a gauze piece and wipe this area or dry this area, and then you start milking the gland from outside. Okay, so what you have to see, you have to see the saliva coming out of it. Okay, observe the saliva which comes out of the duct. Okay, here you also have to look for the quantity and the quality of the saliva. See, quantity, usually when you see the saliva is coming out profusely, easily, that means the salivation is normal. But at the same time, sometimes you see the like pus coming out or purulent material coming out of the duct. That means there is some kind of infection. So always you have to check the quantity as well as the quality of the saliva. And also remember that whenever there is any signs of whenever the patient has hyposalivation or xerostomia or any other sign, usually the, as I told you before also, the mirror will stick to the saliva, and when you do the milking of gland, you will see the saliva which comes out will be more like frothy saliva, or bubbles will be there, okay, rather than the free flowing water or salivation. Okay, these are the normal variation which you see in the buccal mucosa. The first one is a lean. This is white line, a horizontal line along the occlusal line, extending from, this is the commissure up to the retromolar region or the posterior. The next one is leukoedema. Leukoedema appears as a faint translucent membrane, and when you stretch the buccal mucosa, this will disappear completely. Okay. Also, you see Fordyce granules in the buccal mucosa. So all these three are normal variation. Okay. These are some of the pathological finding leukoplakia and lichen planus which you see in the buccal mucosa. Okay, but you see these even in the palate, lips, tongue, anywhere it can be seen. Okay. Now next is examination of the mucobuccal fold. So you have to examine for any change in the color or the presence of swelling or sinus opening in this area. Okay, and always palpate it to elicit any tenderness if present. See, most of the time if there is any kind of sinus opening or any kind of cyst related to the teeth, the patient will have tenderness in the vestibular region. Okay, so always palpate with your finger and look for any kind of tenderness. Okay. Next is palate. So in palate, you have to examine both the hard and the soft palate. Okay. Ask the patient to open the mouth widely, and at the same time, ask the patient to tilt the head back. Okay. So with the help of, if you are in the 7 o'clock position, you can have a direct vision of the palate. And if you are in the 10 o'clock or 11 o'clock position, you can see indirect vision. You can have an indirect vision with the help of mirror, and look for any kind of pigmentation, any kind of tori, any kind of ulcers in the palate or growth or swelling or sinus opening. Look for anything, any abnormality you feel have to be recorded. Okay, these are the common variation you see on the palate, that is palatal tori. You can see it is very difficult to make denture in these patients. Okay, and this is usually seen in the people who are chronic smokers. So if you see carefully here, you see these pinpoint elevation. These are the inflammation of the minor salivary gland, and along with that you also see pigmentation. So this is smoker's palate. Next is examination of the soft palate and oropharynx. Oropharynx is a portion of pharynx which is visualized in the oral cavity. Okay, this area is oropharynx. This should be inspected and movements are examined when the patient says ah. Okay, so how do you say this? You ask the patient to open the mouth widely and depress the patient tongue with the help of tongue depressor or your mouth mirror, and then ask the patient to say ah. So when the patient say ah and you depress the tongue, you will see all these areas. You will see the uvula, you can see the tonsil, and you can see the posterior wall of the this posterior facial pillars. All those things you can see. Okay, and look for any change in the color, size. Okay, any abnormality in the tonsil, if there is any inflammation or enlargement of the tonsil, or check for the movements of uvula. Okay, see for ulceration in this area or pigmentation, and compare bilaterally also. Okay. Okay, can you see here? See, this is the inflammation of tonsil, enlargement of tonsil. Next is examination of the tongue. So you have to examine tongue, the dorsal surface of the tongue, ventral surface of the tongue, as well as the lateral borders of the tongue. So for dorsal surface, you can just ask the patient to protrude the tongue, and you can look for any kind of coating is there, any kind of normal variation in the tongue, any ulcer, any pigmentation, red lesion, white lesion, anything you feel which is not normal, you record it. And also there are many papillas which are present on the tongue. So maximum is filiform papilla, which is seen in the anterior two-third of the tongue on the dorsal surface. This papilla is maximum in number but do not contain taste buds. So remember, filiform, although they are numerous in number, okay, highest in number, but they do not contain taste buds. That means if you keep anything here in the dorsal surface of the tongue in the anterior two-third, you will not get any taste. Even the taste of medicine you will not get. Okay. And fungiform papilla are the mushroom-shaped papilla which are present on the anterior and lateral margin at the anterior two-third, usually at the tip and at the lateral margin. And at the posterior two-third, you have a circumvallate papilla, just anterior, in the posterior part of the tongue. Okay, these are responsible for bitter taste. Usually, the taste of medicine which is very bitter, you get it from these papilla. Okay, and tongue, it is very slippery. So how do you check for the lateral border? You take a gauze piece and then move the tongue on the right side or the left side, and then check the lateral borders of the tongue. Ventral surface you can examine by asking the patient to lift the tongue. Okay. Also, if you see any growth, you should do the palpation of the tongue. On the lateral border of the tongue, you will also see the foliate papilla as well as the lingual tonsil. See, this appears like a growth here, but don't get confused with the growth. This is the normal variation. Okay, this is the anatomy of the tongue itself. So this is lingual tonsil. Don't get confused with any kind of swelling. Okay, now few abnormalities of the tongue or normal variation of the tongue. This includes fissured tongue. Can you see here? These are fissures on the dorsal surface of the tongue. This is tongue tie or ankyloglossia. In this, the patient feel extreme difficulty, to speech. So you have to remove this part by doing minor surgery. Okay, and this is geographic tongue. You can see that many areas of depapillation, and these keep on moving. That is why this name is geographic tongue. Means position of this depapillation is not fixed. Sometime it is here, sometime it will here. Okay, now few pathological abnormalities. Abnormalities of the tongue movement. Usually when you ask the patient to protrude the tongue can, if there is any kind of problem in the nerve, especially the hypoglossal nerve is there, injury or palsy is there, the tongue will deviate towards the affected side. As you see in this picture, the tongue moves towards the affected side. Sometimes you see loss of papilla or the depapillation of the tongue. See here, there is, you don't see any kind of papilla, and the tongue will appear like shiny and completely, bald. So this is seen usually in anemia. Okay. At the same time, when you are asking the patient to put the tongue up to check for the ventral surface of the tongue. Okay, at that time only you should check the floor of the mouth also and look for any kind of growth, ulceration, pigmentation. Okay, and do the palpation also. How do you do palpation? See here you have the opening of submandibular and sublingual salivary gland also. Okay, so if you feel any like stones in the salivary gland, you can do by manual or by digital palpation. So one hand you will keep inside the floor of the mouth, like I'll show you in this picture, and the other hand will be outside, so you can look for any kind of growth. Also, when you are checking the salivation in this area, you have to do same how you did for the parotid gland. Okay, same way you dry the, with the help of gauze piece, dry the openings of the duct, and then do the milking of gland from below the chin and or the lower border of the mandible, below the lower border of the mandible, and then look for salivation. Okay, and check for both the quantity and the quality of saliva. Next is retromolar pad. This is behind the third molar area. This area is retromolar pad. Especially, this is important for the retention of denture. Sometime, if the third molar is not completely erupted, you will see this soft tissue flap covering the third molar. So usually, whatever you eat will get stuck here, and this area will causes inflammation. Okay, so this condition is known as pericoronitis. So how do you treat it? Either you just clean this area and do irrigation, automatically this inflammation will subside, or you have to remove this area soft tissue covering around the tooth. This is known as operculectomy. So you can either remove it or just clean this area. Okay, depending on if the condition is like occurring again and again, you can just remove this area so that the tooth will come out. Okay. Now you have a separate lecture for gingiva, caries, and pulp and periapical disease. Okay, so I will not go into detail. Okay, I'll just to know that you have to do examination of these. I am putting it here, but you have a separate lecture. So there they will tell you each and everything about the periodontium, about the caries examination, as well as the pulp and periapical disease. You all know this is a marginal gingiva, this is interdental papilla, and this is attached gingiva. This is mucobuccal fold. So usually the gingiva is knife-edged, okay, and here you will see the stippling like an orange peel. If you dry this area, you will feel this kind of stippling, okay. So in gingiva, you have to look for signs of inflammation, right? Suppose patient have check whether there is any kind of inflammation, erythema is there, or gingiva is enlarged, or this is inflamed, interdental papilla. Check for bleeding on probing by running the probe, okay, or check for the pocket with the help of this Williams probe. Okay, this will be covered in detail in the next lecture, okay, in the periodontium lecture or gingival disease, but we will give you demonstration in the clinics. So you can see here in the gingivitis, The interdental papilla is inflamed. See here the inflammation, enlargement of the gingiva. See in this also. You can see here recession is there. Okay, mobility. This is a condition which is not inflammatory. It is associated with drugs. Usually, like patient who takes phenytoin. Phenytoin is a medicine used for epilepsy, or patient who are anti-hypertensive. I mean, patient who are hypertensive, they take anti-hypertensive drugs like calcium channel blockers, okay, amlodipine. So all these medicine causes enlargement of the gingiva. So it's not inflammatory, but it is secondary to the drugs. Okay, next is examination of the hard tissue. So first is tooth numbering system we should know, so that whenever you are referring the patient or you are doing the treatment, it is easy to understand. So just have a simple coding so everybody can understand, right, that which tooth you are doing the treatment for or which tooth has problem. Okay, so you have varieties of tooth numbering system. One is Palmer system, which is just represented by the symbol, right? Like this symbol, right quadrant, up left quadrant. And the next one is universal, where the teeth are represented from number starting from 1 to 32, and upper right side you see here. Okay, so 1 8 usually we say it's the number 1 teeth starting from 1 to 8. The central incisor is 8, and then on the other side, left side, starting from 9 to 16. So you have altogether 32 teeth. And same way in the pedo also you have teeth from A to D. But mostly we used FDI or 2-digit system. So you all know about that. You have the teeth from 11 to 18, 21 to 28, 31 to 38, and 41 to 48 for permanent. And for deciduous, 51 to 55, 61 to 65, 71 to 75, and 81 to 85. Okay, also you should look for usually you will get, sometime you will get patient who are 10 year, 12 years, so they will have a mixed dentition. So you always check for the type of dentition, whether it is deciduous, it is mixed, or it is permanent. Look for the present or absence of the teeth. Okay, and always when you are checking the teeth, start from the quadrant 1, start from the teeth number 11 to 18, go to the second quadrant from 21 to 28, then 31 to 38, and then 41 to 48. Okay, these are the if you don't know the eruption pattern, just you should know that the first tooth to erupt is a lower anteriors, okay, and as well as the lower molars, and the last tooth is a upper canine. So if you don't know this, just go through this picture. Okay, examination of the caries will be covered in the caries. You have a separate lecture, so I will not go. I know you mostly you know how to see the caries, so you follow the ICTAS classification. Okay, now next is whenever you see any abnormalities in the tooth, suppose you see caries, you have to write down. Suppose there is a missing tooth, write down. Suppose there is a restoration, suppose there is a fracture or a remaining root or mobility, anything which is not normal with the particular teeth. Each and every tooth has to be recorded separately and along with each surface. Suppose there is a caries on the buccal surface, right buccal surface. Suppose there is a caries also on the lingual surface or the occlusal surface, you have to record it. Also, if there is any missing tooth, impacted tooth, crown, any kind of dental anomalies like mesiodent, supernumerary tooth, anything which you see, you have to record it. Okay, see here, this is caries, this is defective restoration, this is enamel hypoplasia, fractured tooth, recurrent caries, this is cervical caries, fractured restoration, calculus. So all those things you have to record. Here you have a discoloration of the tooth. Okay, this is crown, metallic crown. Next is percussion. See, percussion you do into with the help of a blunt instrument, either the mirror or the probe, and probe you can take, the handle of the mirror usually we take, and you do the percussion either the vertical direction or in the horizontal direction. See here you are doing the percussion in the vertical direction, here you are doing in horizontal direction. So if there is any kind of response, means pain, okay, or sometimes you can also evaluate this with the help of patient body movement, like reflex action, especially in the eyes. They will it will show, like, patient, if they have pain, they will blink the eyes, but even the patient will tell if they have pain. So you can see both the response. Okay, and if the vertical percussion is positive, this is a sign of periapical infection. If this horizontal test is positive, this is a sign of periodontal problem, like maybe pocket is there or periodontal abscess is there. But if this is positive, that means the infection because of caries or because of trauma, there is pulpitis, and then infection has gone to the periapical region, and which is causing this pain. Next is also you should check for the mobility by either with the help of two instruments. You can take a mouth mirror or probe, or you can take one instrument and you can use the other finger. So if there is no mobility, it is score 0. If mobility is greater than 1 millimeter, I mean greater than normal but less than 1 millimeter, it is grade 1. If the mobility is grade more than 1 mm but in buccolingual direction, it is grade 2. If the mobility is more than 1 millimeter in buccolingual direction as well as the tooth is depressible in the socket, that means it's grade 3. Okay, now also there are varieties of there's regressive changes you see in the tooth, like attrition. Okay, attrition is a mechanical wear of the occlusal surface, especially you see people who have bruxism, or nighttime grinding of the teeth, or some patient who are chronic tobacco chewer or ghat chewer, you will see flattening. So this is basically, if you see here, the occlusal surface, the enamel is completely lost. Okay, so this is attrition. Abrasion you usually see in the patient who uses a hard toothbrush in horizontal direction. So this is, you will see notching in the cervical region. So if people who use hard brush and very powerful, very force they are applying, this cervical area will wear off. Erosion is mainly due to chemical wearing of the tooth structure, like people who have acid regurgitation, or many people, they are very fond of drinking colas and Pepsi. So these are commonly seen in those individuals. So same thing, look for any kind of supernumerary tooth, any kind of microdontia, macrodontia, fusion of the teeth, gemination, all those abnormalities you have to look for. So these are the different types of pulp testing. It will be covered later in the pulp and periapical diseases. Occlusion. So occlusion, I'll just explain you with the help of this picture. See, in the class 1, the mesiobuccal cusp of the maxillary molar, first molar, falls on the groove of your mandibular first molar. In class 2, the distobuccal cusp will fall in the groove of your mandibular first molar. Whereas in class 3, the mandible is prognathic, it's ahead of the maxillary. Sometimes the molar is not present. First molar, let's say if it is absent, then you have to go for canine relation. Okay, in canine relation, see, look for if you see the class 1, the mesial slope of the canine falls on the distal slope of the, you can see it overlaps on the distal slope of the mandibular canine. In class 2, you have half unit and full unit. In half unit, they are both at the same level. The tip of the canine of maxillary and mandibular are at the same level. In full unit, the mesial slope of the maxillary fall on the distal slope of the, sorry, the distal slope of the, can you see here, the distal slope of the maxillary canine fall on the mesial slope of the mandibular canine. And here the canine is ahead, the mandibular is prognathic, so it's ahead, there is no relationship between the canine. Okay. Okay, so it's in the class 3. So that's all. If you have any question, any doubt, you can just message me, or you can ask me whenever you have time. No problem. I'll be happy to clear all your doubts. Okay. Thank you so much.